Hi, my name is Andrea Aguilera. My topic about is target gene therapy platform for correction of anemia in early stage renal disease. Definition. Gene therapy is an experimental technique that uses genes to treat or prevent disease. In the future, this technique may allow doctors to treat a disorder by inserting a gene into a patient's cells instead of using drugs or surgery. The technique remains risky and is still under study to make sure that it will be safe and effective. Anemia. Anemia and end-stage renal disease, also known as kidney failure, often go hand in hand. Most people with kidney failure who are on dialysis have anemia. Kidney transplant patients are also at higher risk for anemia.
Fictionalis, let's continue our talk on normocytic anemia, and today's topic will be anemia in chronic kidney disease. In the good old days, we used to call it kidney failure or chronic kidney failure. Now we call it chronic kidney disease because we do not like failure. Symptoms of anemia are the exact same thing: tired, pale, headache, lazy, dizzy, short of breath, on exertion, angina. The signs will include stuff like murmur due to a hyperdynamic circulation and so forth. Here is your hematopoiesis slide. We start with stem cells and we go to RBCs. So in anemia, we're having problem producing enough RBCs. All of these steps need something called EPO, erythropoietin, from your friend the kidney. That's fine. And as you are well aware that MCV determine if the anemia is microcytic, normocytic, or macrocytic. Anemia related to chronic kidney disease is normocytic, MCV 80 to 100 femto liters. Okay, but first I would like to answer the question of the previous video. In the last video on aplastic anemia, there was a question. The answer to the question will be D, phenytoin. Now, back to anemia in chronic kidney disease. As you know, the normocytic anemia, where the MCV is 80 to 100, has three main causes: blood loss, underproduction, overdestruction. Of course, the blood loss has to be acute. Underproduction has many causes. Anemia of chronic disease or iron deficiency, we have talked about them previously, each in a separate video. Aplastic anemia was discussed in the last video. Chronic renal failure or chronic kidney disease, that's today's topic. So let's jump in. So anemia in chronic kidney disease starts at stage 3 chronic kidney disease and is almost universal by stage 4. What are these stages of chronic kidney disease? They are stages depending on the GFR in the chronic kidney disease case. I've discussed them in a separate video called the 5 stages of chronic kidney disease based on GFR. I will link it in the description. What are the causes of anemia in general in cases of chronic kidney disease? A lot of them: relative EPO deficiency, bleeding problem, chronic inflammation, and the link between anemia of chronic inflammation and chronic kidney disease is discussed in my video on anemia of chronic disease. Pardon me. So anemia of chronic inflammation is the same thing as anemia of chronic disease. We have folate or B12 deficiency, hemoglobinopathies, and immunosuppressive drugs. Okay.
Application in medicine. Patients who have had a kidney transplant are at higher risk for anemia. Anemia in kidney transplant patients is caused by having less erythropoietin (EPO) than normal, less iron than normal immunosuppressive drugs. This is because the new kidney betrays some time before it begins to produce a no EPO, and because the patient's iron levels are low from blood loss. Over time, the risk of anemia decreases in patients who have had a kidney transplant as long as their new kidney remains healthy.
I'd like to make the point that I think a lot of us in nephrology today, we tend to think that the patient is anemic when the hemoglobin level is below a point where we can treat with EPO drugs, but that's not really anemia. Anemia is when the hemoglobin goes below, say, 11 or 12, and there are things that we need to do in terms of evaluation at that point. I don't feel at the time of this taping that I really understand why anemia is worse in patients with diabetes. We can certainly think of reasons why that might be the case, but it is.
The stabilized HIF alpha subunit translocates into the nucleus to heterodimerize with HIF beta subunits, activating the hypoxia response genes, which stimulate a host of proteins which impact erythropoiesis, iron availability, angiogenesis, as well as energy utilization. And obviously, as kidney disease progresses, since that's the major source of erythropoietin, there is a relative decrease in the EPO production. It's not eliminated. In fact, the measurable levels of erythropoietin are comparable to what would be expected in a normal individual, albeit not at that degree of anemia. If a normal individual had that degree of anemia, the measurable erythropoietin levels would be significantly elevated because of increased production by the kidney.
And I know a question that probably both of us have received thousands of times over the years speaking about iron is, why do so many of these patients have high ferritin storage iron values at a time that the transferrin saturation or the serum iron is relatively low? And it appears that hepcidin is the reason, iron being locked away in storage tissue and less iron available in the circulation, and to your point, to marrow to be able to produce new red blood cells. So they're a fascinating protein.
These newer agents, first of all, are impacting on an enzyme. That can be done with simple organic molecules, which allows for oral dosing rather than the parenteral dosing of recombinant human erythropoietin. The frequency of dosing may be very different than what we currently have with recombinant product. What we're dealing with these compounds is actually creating a more physiologic approach to the pathophysiology of erythropoiesis in chronic kidney disease.
Whereas the group that was treated with roxadustat shows us a nice increase in hemoglobin by week 4 to approximately 10 grams. And at the end of study here, roxadustat treated patients with chronic kidney disease, not on dialysis, had hemoglobin concentrations of 11. Perhaps as part of the overall treatment of anemia, with the use of these agents, with the HIF stabilizers, there may be this potential to get the additional benefit of liberalizing or freeing up of some of the body's iron stores, which tend to be somewhat restricted in patients who have kidney disease.
Pros and cons. Pros. There were no serious adverse events related to TA-RGT and no signs of a histologic section of TA-RGT excited from patients or excess of anti-erythropoietin antibodies of immunogenicity to TA-RGT or the erythropoietin secreted from the TA-RGT. Cons. This early study does not allow use to assess the risk or benefit of TA-RGT as compared with administration of recombinant erythropoietin injection. Such an assessment will require a prospective randomized trial. Easy to apply in Ecuador. Ecuador is one of the few countries in Latin America where the government and the public health system do not come with genetic service in their hospital. The World Health Organization recommends the presence of a genicity for each 100,000 inhabitants in Latin America, which means Ecuador needs fixing. We currently have 10. Conclusions. All patients who underwent TA-RGT implantations had an initial increase in plasma levels of erythropoietin and plasma levels of hemoglobin remained above or within the desired range for most patients. The plasma levels of erythropoietin remained stable within the psychological range.
So, what exactly is gene therapy? First, let's start with the basics. This is a gene. Genes are made up of DNA, which are the blueprints to build the enzymes or proteins that do the work for your body. As far as we know, humans have between 20,000 and 25,000 genes. And most people have 2 copies of each gene inherited from each of our parents. They are the building blocks of our physical makeup, from the color of our hair, to our athletic abilities, to our immune system. But sometimes genes aren't built correctly. And a small adjustment to the DNA within our genes can change how our proteins work, which can affect how we breathe, walk, or digest food properly. To better understand how genes change, here's Dr. Michelle Kalos.
So our genes are mutating all the time as a result of chemical processes in the cell, as well as external influences like ultraviolet light. We can also inherit mutations from our parents. Now, when we wind up with these mutations, they can sometimes cause disease, and that's really where gene therapy comes in.
If genes are like the blueprint to our body, gene therapy can fill in some missing drawings. Gene therapy is the introduction, removal, or change in genetic material, specifically DNA or its molecule cousin, RNA, into the cells of a patient to repair or change a gene to treat a specific disease. The transferred genetic material then changes how a protein, or group of proteins, is produced by the cell. It can reduce levels of certain disease-causing proteins, increase production of disease-fighting proteins, or even produce new or modified proteins within the cell. You may be curious how a gene and the genetic material it holds is transferred to the cell during gene therapy. Well, a gene cannot be directly inserted into a cell. Instead, a carrier, also known as a vector, helps deliver the gene. Typically, viruses are used as vectors because they've evolved to be very good at sneaking into and infecting cells. But in this case, their motive is to insert the gene or genes into the cell. The infectious part of a virus is removed, allowing it to still enter the cell's nucleus without making the patient sick. It's worth noting there are 2 kinds of gene therapy, in vivo and ex vivo.
In vivo gene therapy, the genes are introduced directly into the patient's cells while the cells are still in the patient's body. In ex vivo gene therapy, cells are removed from the patient's body, then the genes are added to those cells in the lab, and the cells are then returned to the patient. The right approach depends on the disease that the patient has and the tissue that's affected, and that would tell us which is the best way to approach this.
Advanced
Thank you.